Hi everyone, and good evening, good afternoon from wherever you're joining. I am Ayan Nimr, the Medical Science Liaison of the Gulf region at Abu Diabetes Care. Today, we're going to have the first session of the Gulf Diabetes Technology Network. This is a program which we will have 6 virtual sessions from August to December. We will have a program which focuses on critical aspects of diabetes technology. This program is endorsed by the Emirates Nursing Association and by the Diabetic Educators Society, and the program is sponsored by Abbott. The program will be talking and presenting about data interpretation and clinical decision making. We will be talking about evidence-based clinical benefits, as well as patient education strategies, along with integration into clinical practice by our esteemed speakers and diabetic educators. Our first session will be presented today by Ms. Zainab Al-Abadla. So Mrs. Zainab Al-Abadla is a senior diabetic clinical care specialist and head of the diabetes education department at Al Jalila Children's Specialty Hospital in Dubai. She also serves as a clinical instructor at Mohammed bin Rashid University of Medicine and Health Sciences. In 2025, she became American board certified in advanced diabetes management and was recognized as a senior fellow of the International Diabetes Federation, IDF. She has over than 15 years of experience in diabetes education, with experience spanning in pediatric, adult, and antenatal care. And she's highly skilled in advanced diabetes technology. Mrs. Zainab is the president of the Emirates Diabetes Educator Society under the Emirates Nursing Association, leading national initiatives in professional training, community awareness, and research. She is also a published researcher and international speaker committed to advancing equitable access to diabetes care and supporting early prevention strategies across the UAE. Mrs. Zainab, the floor is yours. And today she's going to present for us the topic of CGM Quality Standard. Please go ahead.
Thank you, Ms. Aya, for the nice introduction. Thank you for hosting today's meeting as well. And the big thank you goes to our audience for sparing some time out of your evening to join us in today's meeting. In fact, as Ms. Aya mentioned, Gulf Diabetes Technology Network will be the first of its kind in the Gulf region. And this program, we aim to enhance diabetes management and clinical practice. We aim to enrich your knowledge, especially in diabetes management, and to add to your knowledge about patient education strategies in diabetes care. So I hope that you will find this program beneficial, and thank you for joining us this evening. This session is sponsored by Abbott, and we thought to kick off this meeting with a very important topic to all of us: CGM Quality Standards. And in my talk today, I will try to answer 3 main questions. Why not all CGMs are equal in performance and safety? What quality standards should every CGM meet? And which criteria matter the most when selecting the right CGM? The session of today will be an interactive session. We will have a poll questions. So I want you to engage and participate on those questions to enrich the sharing of data and the learning experience of tonight. So let me start by sharing 2 cases with you. Case number 1 is Miss Amal, 32 years old, woman with type 1 diabetes, diagnosed at age 14. She works as a teacher with a very busy clinic. She is on multiple daily insulin injection with A1C 9.2. She reports frequent hypoglycemia during the night with occasional hyperglycemia after meals. She uses a low-cost CGM device which she purchased it abroad, but she frequently complains of inaccurate readings, specifically with a low glucose readings. The device application she got has poor data security and does not integrate with her clinic's reporting system, which make it very difficult for her to share the data with her healthcare team. The second case is Mr. Umar, 27 years old, man with type 1 diabetes, work as IT engineer. He has flexible working hours and good access to technology. Again, he is on basal bolus insulin with A1C 8.7. He got FDA approved CGM Freestyle Libre 2 Plus 6 months ago, and he is sharing his data with his healthcare team and with two of his caregivers. So, taking the first question of tonight, between the two cases, who is more likely to show better glucose control after after starting CGM therapy? Case number one, case number two, not sure, both cases. What do you think? Okay, excellent. So 63% of you said that second case will get more benefit from starting the CGM, and 15 said both cases, which is good as well. I will not answer this question. I'll keep it at the end of my presentation. We will revisit those cases again and we'll see whether you will change your perspectives after my talk. Looking to the history, there is significant innovation in blood glucose monitoring systems. And looking to what we have in today's market, there is a huge advancement in the landscape of glycemic control, glycemic monitoring in general. So in 1908, back in 1908, the only way to test glucose control was using the urine. And later, or 60 years later, in fact, in 1970, they introduced the classic way of monitoring, which is the blood glucose meters. And 7 years later, in 1977, they start referring to A1C as a measurement of glycemic control. And in fact, the meter and the A1C sustained by their own for a long period, 20 years. They were the only referring test to test or monitor the blood glucose control. 20 years later, in 1999, the first CGM appears in the market. And later, in another 20 years, in 2019, the emerge in the AGP report. I'm sure that most of you familiar with that. So if you can see how the innovation was introduced to the market, it took 60 years from urine to get the first glucose meter, then 20 years to get the first CGM, then another 20 years to get the AGP report. What about the future? In fact, we are living in the future. Those are the well-known players in glycemic control. Those are the five well-known companies and well-known CGMs in the market. However, we are navigating through an era defined by rapid technological advancement. Almost every quarter, we will have a new CGM emerged in the market. As I just showed you, it was like 20 years to get one CGM available in the market. And this because the scientists were studying and applying lots of randomized control trials and researches to introduce certain medical device into markets. However, nowadays, we are getting lots of CGMs. So this will keep us as healthcare professionals uncertain whether those devices are accurate enough. Are they backed and well supported with studies to ensure their safety and accuracy to be used for our patients? To answer this question and to tackle the first question whether all those CGMs are equal or not, we'll take the second poly question. Among all those CGMs currently available in the market, how many have received FDA approval? One only? All of them? Three only? None of them? Or five only? Okay, so 25 of you said five only. 41 of you said three only, and 21 of you said all of them. I will surprise you. I will surprise you and tell you that among all those available CGMs in the market, only three of them got the FDA approval. And in our region, the Gulf region, only two devices are available out of those three. I will tackle in my today's presentation what's FDA approved approval means and what standards should those CGM meet to ensure the accuracy and high performance to our patient. But this tells you that it is to get an FDA approval, it is not easy and it is challenging. Why is that? Because FDA has a very strict and high standard to ensure the safety of devices or medical devices we are introducing to our patients. So this will answer, this is the first answer to our question, why not all CGMs are equal? Because many new CGMs which exist in the market are not FDA approved. The second answer to this question, some of those devices which recently introduced to the market and start being used by our patients showed poor accuracy, especially at low and high glucose ranges. In fact, the market is very big and you can't control the patients. The patient has access to the social media. They have a group, in fact, to share data, and they introduce those machines among each other. So the patients might go and get this machine by themselves from the market and it's available without prescription even. So how would we ensure that our patients are using the right device and getting the right correct data to share with you as a clinician? So in fact, some countries reported poor accuracy of those devices. For example, issues with device accuracy and safety have been reported outside USA. In a region of Italy, poor accuracy at low and high glucose level was reported with a CGM device awarded in tenders. And the inaccuracy and the mismatch between blood glucose readings and the sensor readings was very serious, to an extent that the clinician recommended for the users to return back to the finger stick blood glucose monitoring, and they have reported this in their national magazines and withdraw it from the market. Again, in UK, the NHS blacklisted two of those CGMs not to be prescribed because they reported a poor accuracy and mismatch between blood glucose and a huge difference between blood glucose and sensor glucose. So inaccurate CGM, in fact, can miss hypoglycemia and specifically the low and high reading, both which can lead to inappropriate treatment decisions and might lead to a serious adverse events. To share a personal experience from our hospital, one of the patient presented to our hospital with this kind of CGM called Otai, and he brought this CGM from China, and it took lots of time from our colleagues to download the CGM and to extract the data from the system. In fact, they failed to do that, and they asked the mother to download it from the app and to share it with them in their emails, in our email. And imagine the report she shared with us. How does it look like? So this is the first page, and those are the following reports. So I assume that this might be AGP with some limitations. And those are the time in range and time above range, time below range. Of course, we can't rely on this data. We don't know the accuracy of the data. We don't know the whether the lows and highs are accurate lows and highs or not. We don't have any idea about even the language. We could not change it to English or to any other understandable language. Of course, we stopped this device totally and we offered the patient with well-known CGM, and this was his reading 2 weeks later when he presented to our clinic. Yes, he is not yet into target, but at least now we have some data which is trustworthy and we can depend on for clinical decision, isn't it? So as I said, that the market is huge, the market is open. We can't stop patients from getting such devices, but we clinicians should guide them what devices they should use and why they should rely on high quality and high performance CGMs, because they are directly related and correlated to their daily clinical decisions. So, talking about accuracy, I'm sure that some of you or most of you are using MARD as a metric for evaluating the accuracy. So, does MARD, the mean absolute relative difference metric, provide a sufficient measure of sensor accuracy? Yes, no, not sure, first time to hear about MARD. Interesting. So half of you said that yes, MARD is a sufficient measure of sensor accuracy, and around 18% said I don't know what's MARD, which is again excellent because I'll be adding to your knowledge today. Let me surprise the 50% who said yes and tell you. I don't know why slides are not moving easily after each question. Yes, so let me surprise you and tell you MARD alone is insufficient to tell you about accuracy, and let us know why. MARD is it's an absolute relative difference. It will give you an average overview of the difference between the glucose reading from the sensory glucose reading, and the blood glucose reading. So basically, for the people who doesn't know, it is a way of testing the accuracy of the sensor. So it will show you how much there is difference between blood glucose or plasma glucose and sensory glucose. So lower the MARD is better the accuracy, roughly. So we always say if the MARD is less, it means that there is less difference between the plasma glucose and the sensory glucose reading. However, MARD is giving us an average overview of the glucose accuracy. It does not test for the excursion. It does not test for the outliers. It doesn't test for the sensor error. It doesn't test or doesn't include all the readings in highs and lows. So showing you this graph in stimulation A, when they tested the MARD without looking to the outliers, it shows them 8%. However, when they adjusted the outliers, when they adjusted the error, the MARD increased from 8 to 12. So yes, MARD might tell us about the average accuracy, but it won't tell us about clinical risk and outliers or the dangerous errors, especially with highs and lows. So some newly emerged CGM in the market, they may tell you that we got the same MARD of Freestyle Libre or we got the same MARD of Dexcom. Yes, this is their average MARD. But if you ask them about their adjusted MARD, about the MARD which tested lows and highs, there you will be surprised that their MARD will be increased to 15%. And it is written in their label, you can go back and check it. So I want every one of you now not to depend anymore on MARD. If any company will introduce their device and tell you our MARD is 8, go back and check for excursions, go back and check for the adjusted MARD, and which is the real MARD after they adjust for the outliers. So now we need to see the accuracy, in fact, beyond the MARD. Test the accuracy across the entire glucose range and for each individual measurement, not only to see the average of the accuracy. And in fact, we need to look into the data. If you will see here the target circle or target board, this is what we need to look into. Our data should be high precision and high accuracy. When I say precision, it should be, do we mean by precision is the consistency. So the data or the difference between glucose data and blood glucose should be less, not more than 20 milligram per deciliter, and consistent. So all the times when the patient will check lows and highs, any times of the day, the difference should be less from 15 to 20 milligram difference only. So the data, because some CGMs might be consistently wrong, but still with a good mark. So it should be precise enough. You should get a consistent data of accuracy, and the mark should be low, both of them. So does the mark give us full picture and evaluate the full performance of CGM? In fact, no. The mark doesn't evaluate for the distribution of error. Imagine if this guy wanted to cross the river, and this guy is 2 meter length, and he was told that the river average depth is 1.5. Okay? Excuse me. So yes, if we measure the near to the shore, the depth is 1, and in the center the depth is 2.5, this will give us an average of 1.5. And if he cross the river, he will drown in the middle. Isn't it? Why is that? Because they give him the average of the river by taking the edge and the middle. So exactly the MARD. MARD is like knowing only the average depth of the river. It does not tell us about the deep spots that could be dangerous. So in CGM, it means that a device could have a good average error, but still give us unsafe reading at lows and highs glucose levels. That's why CGM demand full testing to ensure safety across all situations and the average glucose. So MARD alone might not reflect a clinical accuracy entire the whole glucose ranges. And yes, it's important. All readings by the patients and all readings that the patients see in the meter is important, because each reading matters when the patient wanted to make a self-management decision, specifically including insulin doses. So MARD is a single value that might mask an errors or significant errors in specific glucose ranges, and it does not count for clinical impact of errors. So from now on, we should start looking beyond the MARD to evaluate the CGM for its accuracy. So by that, I answered the first question, why CGMs are not equal. Because not all of them are FDA approved. Some of them already reported a poor accuracy in the market, although they are CE market approved and showed or announced with low MARD, let us say. And now we discovered that the MARD alone is insufficient to evaluate the accuracy of the reading. So since not all CGMs are equal, what standards every CGM should meet, must meet? To answer this question, first, the CGM should replace SMBG, should replace the self-monitoring blood glucose reading. And before getting the MARD to your clinic or before getting the CGM to your clinic and introduce it to your patient, you should ask yourself a question whether this CGM is adjunctive CGM or non-adjunctive CGM. Adjunctive CGM means that it cannot replace the finger stick testing. Non-adjunctive CGM, it's a standalone device, and it can replace the finger stick testing, and you can take a medical decision based on that CGM. And it's not the secret, nothing hidden. They mentioned it very clearly in their label. They say that CGM system should not be relied on for treatment decision or therapy adjustment. There's another company labeled here that measurement should not be used to make treatment adjustment, but rather a reminder of when finger step testing is required. So if CGM cannot replace SMBG, how it would be beneficial to our patients? How would we ensure that the quality of life for our patient is improved, and we actually use those technology to add flexibility to our patient's life, to make it more easy, to make them more confident, to decrease the burden of such chronic disease, take it off their shoulder. So if the CGM doesn't replace SMBG, in fact, I think that this will add burden to the burden. And unlike the non-adjunctive CGMs available in the market, both of them clearly labeled that it is designed to replace finger blood glucose testing for treatment decision, and it is intended to replace glucose testing for diabetes treatment. So the two available CGMs in the market are, you can rely on them, and they can replace SMBG for treatment decision. So you start introducing CGM, which they are non-adjunctive CGMs only. The second answer to the question whether this CGM is FDA cleared or not. In fact, as I mentioned in the very beginning in my presentation, that FDA clearance is very difficult and very strict. They have like list of standards. I will just share them in a while. And you need to clear all standards to get the FDA approval. And we can't assume at all that other CGMs available in the market would have the same performance and same safety and same accuracy as FDA approved CGM. And let me show you why. We have two medical devices for we have two medical bodies to approve medical devices. The FDA, the Food and Drug Administration regulations for medical devices, and the CE marking for medical devices, which is Europe bodies. Are they the same? For the CE mark approval, are there minimum performance requirement for a CGM to get CE mark approved today? The answer is no. There is no specific CGM standards to get CE mark approval. So if any company who will introduce CGM to you until yes, we got the CE mark approval, this doesn't add any value to the CGM. In fact, the CE mark approval has no defined accuracy and performance metric. And imagine, it does not guarantee that this CGM has been adequately assessed for accuracy and reliability or even for safety. Unlike other devices listed under the CE mark approval, for example, the pacemaker, they have label, blood glucose monitoring, they have ISO label, insulin pump, they are labeled for safety and accuracy, but CGM has none. They listed it as no harm device. As long as this device doesn't introduce a clear harm to the patient, it can be approved by CE market. Imagine, as if they are listing it as if it's a calculator or it is any electrical device available in the market. So there is no specification for CE mark to approve their CGM. What about FDA approval? What are those standards? To get FDA clearance for safety and accuracy and high performance, the CGM device should meet all those standards from A to K. And those standards are independent standards. What do I mean by that? That those conditions should all of them be met. You should meet A and B and C and D, not or. All of them should be met. And all of them should be met in pediatric subject as well. And they should be, or they should show consistency throughout the sensor life. Not only that, it must present accuracy in intended population, type 1, type 2, pediatric pregnancy, and throughout the measurement range of the device. So FDA CGM standards include rigorous testing to ensure reliable performance across all glucose reading. It is the strictest regulatory framework worldwide. So you can't assume that any CGM who got CE mark approval is like an FDA approved CGM. And imagine that FDA doesn't look to a minimum mod. They don't care about the average mod. They care about accuracy in every condition and every glucose target measured by the CGM. All of them, CGM approved devices must demonstrate reliability and accuracy across all glucose ranges and rapid changes, with lows and highs, with normal reading and with quick changes, not like other devices which are approved only using the mark, and which now proved that it might miss an error in critical clinical situations. So strict quality standard to ensure patient safety, like FDA clearance ones, should be there. CGM accuracy and performance should be backed with robust clinical data, should be representative across all target population, and proven across the dynamic glucose ranges. So in fact, every and each CGM should be FDA approved if you want to ensure the safety and high performance, and if you want to rely on this kind of CGM and use it in your clinical practice. Third answer to my question, what quality standard you must have in your clinic, is cybersecurity and personal data protection laws. Talking about Libri specifically, they meet international security policy. In fact, they meet International Organization for Standardization, and they ensure that information security management, including patient data and continuous monitoring, are secured, and they got certification for medical devices that guarantee that the system handling the healthcare data are safe and reliable. And also, they comply with HIPAA and GDPR, global privacy regulation, to ensure protection of patient health data. Also, they introduce, if you notice, like I think 3 years back, we start having extra security of two-factor authentication. Now, when you leave your Libri account for 14 days, it asks you to enter to verify your email or phone number and get a code to have access to the data if you left your account within 14 days or not been used for the last 14 days. So this is an extra security on the patient data and patient confidentiality. In Middle East specifically, for other CGMs and Libri, the data is stored securely in Amazon Web Services, AWS, in Ireland. Talking about UAE specifically, since November 2021, Dubai hosted the data. So the server became local server in Dubai for Freestyle Libre patient data, and this to align with the federal law to 2019. So this will ensure a high personal data protection and high patient confidentiality alignments. So what your CGM must have: sensor survival rate. And sensor survival rate defined or assessed by the percent of how long the sensor remain operational. remain functional, remain active. How many times the patient will come to your clinic, and I always say that you need to look into the sensor active time. If the sensor active time, and this is as per to the consensus guidelines, below 70%, you can't rely on this data to take your clinical decision. And this is in fact very important when it comes to the sensor survival rate. And for Libre, Freestyle Libre 2, they tested now I'm talking about Freestyle Libre 2 Plus. The wear duration days are 15 days. So they tested the sensor survival rate, and it shows 95% of survival rate. Of course, higher survival rate, more reliability, and more representation of the data. So Freestyle Libre 2 Plus showed 95 of sensor survival rate. And this means that the falling rate is less, the connectivity issues is less, the error of data capturing is less, and the sensor is able to give us 95% of the data. And this will tell you and ensure you as a healthcare professional or a clinician that you can rely on this CGM, which will present 95 of the data, which is reliable for you to make your clinical decision based on it. The last answer to our second question is robust clinical trials and significant outcomes. In fact, we have wealthy of data supporting the use of those kind of CGMs in enhancing and improving the glycemic control in wide ranges of blood glucose and in different populations, type 1, type 2, adults, pediatric, and pregnancy. It's proven to significantly lower A1C, less time in hypoglycemia, and increases time in range. And those studies are randomized controlled trials in different population, different country, and even different age group. And as I showed you in the very beginning slide, that it took from the scientists 20 years to introduce the first CGM. Why is that? Because they don't offer us with CGM unless it is packed and supported with very well designed randomized controlled trials to prove its accuracy and a significant impact on glycemic control. So I answered the second question, quality standard should every CGM meet? So know that not all CGMs are equal. And when you wanted to choose and select CGM or introduce CGM to your clinic, what standard your CGM should meet. And now, since we have the standards and know the accurate and high performed CGMs available in the market, what selection criteria shall we use to select among CGM and offer our patients with? Before I answer this question and share with you a nice data, I wanted to hear from you. When choosing a CGM for your patient, which of the following factors influence your decision the most? And I wanted you to answer this out of your perspectives, not out of, I will share with you the guidelines. I want to know from your perspectives. What do you think? What factors influence you the most? Because I will show you mine in a while. You still use the guidelines. So 39% of you said hypoglycemia and awareness will influence their decision. 23% said age and lifestyle, and 29 said accessibility and affordability. Only 9% said patient preferences, and if you ask me, I will go with patient preferences, by the way, and I will tell you why in the coming slides. Okay, let me move. But this is a personal perspective. It's not a guidelines. The guidelines says yes, sometimes hypoglycemia and awareness will play a role, and let us navigate through them and figure them out in my coming slides. Okay. Before sharing with you the selection criteria, I would share with you the guidelines, what the guideline says when it comes to CGM. So ADA guidelines and EASD guidelines in 2023 says that regardless to the glycemic target, whether the patient met or did not meet the glycemic target, CGM should offer to every type 1 patients with MDI. Okay, so all type 1 patients, regardless whether they are under control or not, they should have CGM as a therapy for their treatment. When it comes to type 2 and different case scenarios, ADA guidelines and ACE guidelines 2023 strongly recommended that all adults with multiple daily insulin injections or on pumps should have CGM. They recommended that adult on basal insulin should have CGM, problematic hypoglycemia should have CGM, pregnant women type 1 or type 2 on intensive insulin should have CGM, GDM on insulin should have CGM. So in summary, different patients on insulin, they have to have CGM. May be recommended for GDM patients not on insulin and type 2 diabetic patients who are on less intensive insulin or oral therapy. However, ADA guidelines changed in 2025 and they said that type 2 adults on glucose lowering medications, not necessarily insulin, other than insulin should be offered CGM. And why is that? Because CGM showed a strong clinical impact on glycemic control and in optimization of the glycemic control, regardless whether the patient is type 1, type 2, whether the patient is on insulin or using a glucose lowering agent. And I'm sure that in the near future, using CGM will be one of the diabetes clinical care standards. Coming to the specific selection criteria, I did not find anything in the guideline. And those are my selection criteria. In fact, I read a lot before I can list those criteria to you. Too many papers. Different papers has different perspective, different research proving different point. But I was able at least to the end to link the commonalities between papers, researches, and evidence-based. And I could categorize the selection criteria to 8 different categories. So let us explore them together. First of all, age and lifestyle. So now the CGM available in the market approved from age 2 and above. I'm talking about Dexcom G7 and Libre 2 Plus. However, if you have Libre 2, it is approved from age 4 and above. So you need to mind the age in this case. But here in United Arab Emirates, the availability of CGM, both of them are approved from age 2 and above. So age for us is not an issue. You need to mind active lifestyle and consider adhesive durability and size. Again, some CGM differ in their size. So for example, if your patient is lean, has less fatty tissue, you can choose a smaller CGM, lighter CGM for the patient. Again, if the patient is using certain CGM and complain of adhesive, high falling rate, you might change CGM or offer different CGM based on the adhesive durability. So in fact, we don't talk here accuracy, we talk age and lifestyle based on your patient clinical characteristics. Digital literacy and access. So smartphone compatibility is selection criteria. So if your patient phone is compatible with certain device, not on the other, of course, you will not ask your patient to go and buy a new phone because you wanted to start him on certain CGM. So you will offer the patient with the CGM which is compatible with his device, and he can download the app on those devices. Again, whether the patient wanted a real-time data or the patient is happy with the scanning. Whether the patient wanted an auto-calibrated CGM or the patient wanted to enter calibration to his CGM. So we tackling here digital literacy and accessibility. So based on patient preferences, based on the digital literacy, you might choose the CGM for your patient. site reaction and skin sensitivity. If the patient develop a site reaction or skin sensitivity from the current CGM he is using, of course, first we need to evaluate the history of site irritation and allergy to adhesive. We need to offer the patient a hypoallergic patches, but if it did not work and the patient still complains of skin sensitivity, we need to switch between CGMs. And some CGMs are applied only into arms. Other CGMs can offer you a different site of insertion, like abdomen and back of the arm. So again, site selection criteria is important when the patient complains of skin sensitivity and skin reaction. Patient preferences. Some patients will come to your clinic tells you that I wanted this device. And I read about this device. My cousin is using this device. Even if you offer them different devices, the market today and our patient today, specifically the young generation, before they present to your clinic, they read a lot and they know lots of information about the devices. So if they prefer certain devices and there is no harm, you should go with your patient preferences because the patient will trust this device more than any other devices you may offer the patient with. Again, noises, alerts, and alarms. Some devices might introduce or cause alarms fatigue for the patient. So if you feel that your patient gets anxious easily, your patient might get stressed for different because of lots of alarms and alerts, then you might offer him a device where we can switch on the alerts and alarms, or a device which doesn't cause alerts fatigue. Okay. 5 is anticipating future insulin pump integration. If your patient expressed that they wanted to have, for example, Omnipod 5, you can't offer them Freestyle Libre 2. It should be Freestyle Libre 2 Plus because Freestyle Libre 2 Plus is integrated with Tandem T-Slim and with Omnipod 5. So you need to know your patient plan, future plan, and you need to agree with your patient plan just to minimize the system changes for the patient. So if the patient anticipating a future insulin pump integration, you should choose the right CGM from the beginning to lessen the system changes for the patient later on in the future. Hypoglycemia and awareness, as per to the guidelines, that if the patient got hypoglycemia and awareness means that the patient did not, the patient will lose the sense of hypoglycemia. So the patient might go into hypoglycemia without feeling the symptoms. So usually we introduce a real-time CGM for patients where the CGM has urgent low alarms, and those urgent low alarms cannot be switched off. So in the CGM application, there are some low alerts that you can switch them off, but other devices might not allow you to switch the alarms off, specifically if the patient is having hypoglycemia and awareness. So usually we advise the patient to use this kind of CGMs because of the risk might happen if the patient went hypoglycemic without getting aware. Comfort, easy of use. If the patient is elderly, if the patient has, for example, it doesn't like to handle technology, we always introduce for the patient a single piece sensor. But if the patient is young and happy to have different pieces, connect them together, we can introduce a slightly larger CGM. So again, you will introduce the CGM size, the CGM accessories based on the comfort and easy use of the patient. Accessibility, affordability issues, and cost, it plays a big role here. In fact, continuum of care is very important. I don't introduce any device for the patient where I might, in the near future, tell the patient, stop this device. I don't like to give patient a CGM to use it for 2 weeks and start feeling the difference between SMBG and sensory glucose, start knowing how much the patients who are using the CGMs has flexibility, and then those patients can't afford the CGM in the after the coming 2 weeks. So cost is an issue. Insurance is an issue. When you afford your patient with a technology, make sure that the insurance will cover that, or make sure that the patient can pay out of their pocket and continuously have those devices. Don't let the patient in the midway uncertain what to do, how to continue, how to bring this device again or get this device again. So cost is an issue. It might affect our selection. So always we will ask the patient if they are cash payers, and insurance coverage plan is an issue as well. So, to summarize the selection criteria, in fact, there is no one size fits all. Personalization here is the key. We need to evaluate clinical factors, lifestyle, patient preferences to offer the patient CGM. For me, and after I shared with you the data, both FDA approved devices available in the market offer an excellent tool when it matches the right patient profile. So both of them are excellent, both of them are accurate. By now, I answered all the three questions. Why not all CGMs are equals? What quality standard should every CGM meet? And which criteria matters the most when selecting the right CGM? Going back to our cases, Miss Amal, let me share with you challenges that Miss Amal faced. She faced challenges with accuracy concerns. Her CGM readings was mismatch between finger sticks, and most of the time it was off by 40 milligram per deciliter. Her sensor reliability as well was about 30% of the sensor stopped working before intended wear time. And this, in fact, imposed an emotional impact. She was frustrated, she was and that boost her motivation to manage her diabetes and to interact with those data. And she was uncertain and afraid to make a clinical decision based on her CGM data. How we would link this to our three objectives of today. Why not all CGMs are equal? Amal has low-cost device which lack FDA approval standards, leading to poor accuracy and safety risk. What standards should CGM meet? If her device met CGM standard, it would ensure consistency, accuracy, and secure data handling and will be reliable, covering the whole wear time. What are the key criteria for selection? Amal would benefit more from CGM chosen based on the guideline selection, which is accuracy, data integration, reliability, and alignment with her lifestyle. Going to our gentleman, Mr. Omar. The positive factor of Mr. Amar that his device was consistent, meets CGM standard, and in fact, he was referring and engaged with his reading more than 12 times a day, and he was taking accurate medical decision based on those readings, which shown is on his A1C, which drops after 3 months to 7.3, and his time in range improved to 65%. And psychologically, he is confident to handle his diabetes and manage his data because what he gets from the CGM is an accurate data and with high performance and quality standards. So to link him to our objective today, why not all CGMs are equal? Unlike Amal, she has non-standard device, but Mr. Amar, his device meets rigorous FDA criteria, ensured accuracy and reliability. What standards should meet? In fact, Mr. Amar CGM adhere to accuracy and data security sensor survivor standard, making it clinically safe, and he was referring more than 12 times to his CGM and interact with his glucose reading. What are the key criteria of selection? His choice was based on guidelines, on lifestyle fit, and data integration, including ensure that the device met his clinical and personal needs. So the difference is clear, in fact. Amal's experience with low cost, non standard CGM highlights risk, while Umar uses of this kind of CGM showed how applying the right standards and support him with a high quality CGM would optimize the outcome. So quality matters, keep your patient safe. Key takeaway messages when it comes to clinical outcomes and patient safety, not all CGM are equal. Every CGM should meet a strict benchmark, non-adjunctive use, strong cybersecurity, evidence from robust clinical trials to ensure high performance. Devices that lack FDA CGM standard often shows poor accuracy and poor reliability, putting your patient safety at risk. Selection of CGM must be personalized based on clinical factors, lifestyle, psychological factors, readiness of the person, and all those should guide your choice. But in the end, as I said, both are perfect tools, and there is no one size fits all. By that, I came to the end of my presentation, and I would like to thank you for staying with me till the end. And I would ask all the audience to scan this barcode and join us for our Diabetes Educator Society. So you will be aware of the upcoming sessions of this network, which will be announced in our society, inshallah. And independently from I'm not sure whether you scanned the barcode, so I'll give you 30 seconds to scan the code and join. We will be grateful and honored if you will join our society. Also, I would like to ask you to scan this barcode to participate with us in assessing HCP healthcare professional knowledge on enhancing theme park experience. In fact, we are implementing a survey. We wanted to know your knowledge on enhancing the patients, specifically type 1 patients, when they are in theme park. So are you having enough knowledge to educate your patients on how to handle the theme park activities or not? And technology plays a big part on this kind of activity. So we would like you to scan the barcode and to participate with us in our survey. This is independent survey, not related to Abbott.
Thank you, Zainab, for the informative session. While the audience scan the QR code for the survey, also we would love for you to drop your question in the Q&A section. We have a section for questions, so please drop any question you have for the speaker related to the presentation on that box so we can answer that.
Okay. I will start reading the first question. Can we use the CGM to understand patient spike for type 2 diabetic patient and help them to support and attain HbA1c below 7 for 60 year old? So it is to understand the routine of the patient and would not be used continuously as they cannot afford CGM. I assume that the question is about the FDA approved CGM. Yes, you can do that, but you need to align and agree with your patient about the purpose of using the CGM. When you introduce any device on any treatment, I hope that you engage the patient on the clinical decision. And patient should agree on the objective. You and the patient, you should have a mutual agreement on the objectives. So if you agree with your patient that you would use this device, for example, for only 3 months, getting his A1C, and we are doing that in the clinical practice, for just to get his A1C below 7, and then we discontinue the CGM because of the financial impact. If your patient agreed with that, yes, you can do that, absolutely. And believe me that if the patient start using the CGM and see how much the data the CGM can provide the patient with, and the impact of CGM on his glycemic metric, they will be very reluctant to stop the CGM completely. They will keep telling you that let us use it 2 weeks and take a break another 2 weeks, but they won't stop it completely. But yes, you can do that, and we are doing that in the clinical practice. What to do if there are discrepancies between CGM and glucose meter, and what is the acceptable difference? This is very nice question, and I expected this question, in fact, in today's talk. First of all, the acceptable range is between 15 to 20 milligram. And why is that? We have always lag time. We have always lag time between blood glucose reading and sensory glucose reading, because the data which you see in the blood takes time until it is circulated and reach to the sensor where it is applied in the fatty area. So there is a 20 minutes, 15 to 20 minutes lag time. So in fact, what the reading which the patient see in the blood, it will be reflected in the coming 20 minutes in the sensor data. So patient should understand that this difference is about the lag time. So the patient will still see those readings in the coming 20 minutes. And even if the difference was 20, this is acceptable. Now, the second part, if there is discrepancies, what you need to do, in fact, you should teach your patient, and we do this in our clinic and we have it in our educational modules, because this is very important to be mentioned to your patient, to trust the device. How many times the patient will come to you, tell you that this is not a trustable devices, there is a huge difference, I can't use this device, it gives me different data. Because, and this, the reason of this, for me, I see that the reason of this is the lack of education. So you need to educate the patient when to check for CGM accuracy. Patient should check for CGM accuracy when his blood glucose is stable. When are the stable times? When the patient wake up in the morning, blood glucose will be stable. 4 hours after meals, blood glucose will be stable. Or immediately before meals, blood glucose will be stable. So if the patient will wanted to check the accuracy or the difference between the blood glucose data and the sensor data, he should choose a stable time to check the difference. But he can't use, for example, after hypoglycemia to check the difference, because absolutely there will be difference between blood glucose and sensory glucose. Patient just took juices and the juice will be high, reflect high blood glucose in the blood and not yet reach to the sensor. So it will be high in the blood and low in the sensor. He cannot test for accuracy after food, because we have different food absorption, we have simple carbs, we have complex carbs. So 2 hours to 4 hours after meals, he can't use this time to check the accuracy of blood glucose, because again, we have factors that might affect the stability of blood glucose. He can't check blood glucose after exercise, because again, he might have difference in blood glucose data and sensory glucose data. So if your patient wanted to check the accuracy of the device, advise the patient to use a stable timings to test for the accuracy, which they are fasting, if he has no hypoglycemia on fasting, before meals 4 hours after meals, and can be before exercise. But he can't check the accuracy after hypoglycemia, after food, after exercise. What do you have experience with CGM in diabetic patient on dialysis? In fact, as per to the guidelines, it's not recommended to use CGM on dialysis patient. Maybe Aya can add to this, because the CGM depends on the fluids around the sensor. And patients who are on dialysis have issue with fluid retention and fluid shift. So we don't, in fact, ensure the accuracy of CGM on dialysis patients. So no, we always offer our dialysis patients to use the classic way of monitoring which is SMBG. Aya, do you have different experience on that?
Yeah, thank you, Zainab, for mentioning that. So this is it. But I want to add one more thing that we don't. The use of CGM is not tested. Patient on dialysis, it's not tested. So that's to be off-label. And since there is no studies on that, as you said, based on the dialysis patient and the fluid, so we don't recommend to use. It's off-label and it's not approved for use during dialysis.
Okay. Well, I think she is the same one who asked the second question, and this is continuation. She said, but what if the meter is not accurate, not the CGM? This session is not to handle meter devices and accuracy about the meter. This is different issue and different story. But we assume that you should ask your patient to use an FDA approved meters with high quality to test the CGM with. Ahmed Mansour, you sent me a question mark, but I did not get the question.
I think they're asking about the CME.
Okay. The first session, today's session is not a CME accredited session. However, this is something we will introduce because we can see that many of you have concerned about it. So we will try to introduce this from the coming sessions, inshallah.
So if there is no more questions, I think we have come to the end of our first session of the Gulf Diabetes Technology Network. I'd like to extend our sincere thanks to our speaker, Mrs. Zainab Al-Abadla, for the insightful and impactful presentation. To all the audience, thank you for taking the time to attend this session, and your presence has made the session stronger, and we hope that this will be meaningful collaboration journey ahead. We look forward to welcoming you on our upcoming sessions. So until then, please scan the code to stay updated with the next session. Thank you once again, and have a great day.
Thank you. Thank you, Aya.
Thank you, Zainab. Thank you, everyone.
Bye-bye. Thank you, everyone. Good evening. Have a great evening. Bye-bye.